Hello, my name is Michelle Kahulis, and welcome to our very first virtual meeting. I'm one of the primary care physicians, and today we'll be talking about advanced care planning. I'm going to touch base about why I think it's important, how to incorporate it into your already busy schedule, how to complete the PULSE form, and how to bill for the Medicare Advanced Care Planning visit. Just as a little background about myself, before coming to Summit Medical Group, I worked as a hospitalist and was the head of palliative care at Roosevelt Hospital in the city. For those of you who round in the hospital on critically ill patients, you may have been put in the unfortunate position of having to help families make medical decisions for their loved ones who are unable to speak for themselves, whether it be due to delirium or altered mental status. In many of these cases, the patient has never talked about advance directives with their family or their physicians. There's no living will or pulse form, and the family may have no idea how really sick the patient is. These conversations are infrequent. Fewer than one-third of patients with end-stage diagnoses had end-of-life discussions with their physicians. They also occur too late. More than half of initial end-of-life discussions have occurred in the hospital. And in patients with advanced cancer, the first end-of-life discussion occurred 33 days before their death. This can lead to increased stress on the family and physicians taking care of the patient, as the patient may not be able to give any guidance because they're delirious or have altered mental status. Having early conversations in the outpatient setting can lead to better outcomes. Patients are able to use their values to help determine their care, and they're happier that they're given the ability to make an autonomous decision. It will also improve costs. In 2011, Medicare spending was $554 billion, and of this, 28%, or $170 billion, were spent on the last 6 months of a patient's life. This was often due to ICU stays, aggressive hospitalizations, and interventions, and more often than not, the treatments did not change the outcome or improve the quality of life. Now, I'm sure the question you're all thinking is, how do I fit in an annual wellness visit, a chronic care visit, and an advanced care planning all into one 30-minute visit, in addition to doing all the stuff we're responsible for in the QM tab? Well, hopefully I'll give you a few tips to help make this a little easier. Some of the barriers to having these discussions is that there's not enough time in the visit. We also may not feel very comfortable having the conversations, and we're wondering how we're going to get paid for it. A majority of our patients are very healthy, and we may not feel that there's a need to have these conversations with them. And if you don't have an established relationship with the patient, it may be hard to bring this up. From the patient's perspective, they really don't feel comfortable talking about dying in general. And as you may remember from Obamacare, there's this fear that there's this Obama death squad, that if you decide to be DNR, DNI, that we're not going to do anything for you. And finally, a lot of patients would rather their family or the physician make their decision for them. Some ways to overcome these barriers are to start the conversation early. It's often easier to have an advance directive conversation when the patient is healthy instead of when they're at the end stage of their disease. As a primary care physician, doing it as part of every annual wellness visit, you can review their wishes annually. For specialists, you can make it a part of your annual evaluation for stable but serious medical conditions, and also consider having the conversation when a chronic condition seems to be progressing. It does get easier the more you do it, and just keep in the back of your mind that you don't have to complete a PULSE form on the first time you discuss it with the patient. You can always readdress it at later visits, or even encourage them to bring their family into the next office visit so you can have a full family discussion. We need to focus on our high-risk patients. These are the ones who see our subspecialists very frequently. For example, those with end-stage renal disease, end-stage heart failure, severe COPD, worsening dementia. Our hospitalists know them well as they are frequent flyers and are constantly in and out of the hospital. In addition, our goal should be to have these discussions with all patients over the age of 70, even if they are well. I'm going to go through some key phrases that you can use when having these discussions, but this is another resource that you can use in case you wanted more information. With every annual wellness visit, I bring up advanced directives. So after doing the template, talking about their chronic conditions, going through the preventative things like vaccines, mammograms, pap smears, I say the final thing we need to talk about today is your advanced directives or living will. I ask if they have one. Oftentimes they'll say, yes, I do, but when I ask them what it says, they give me a blank look. Then they say, oh, my lawyer drew it up. My husband is my decision maker and he knows what I want. I think the most important benefit of having this discussion with someone is that we let them know that we, the doctors, the healthcare team taking care of them, would like to know what matters to them most, so that we can all work together to ensure that their goals of care are respected and that nothing happens to them that they don't want to happen. As mentioned in an earlier slide, in patients with advanced cancer, the first end of life discussion happens on average about 33 days before their death. So, one of the first things you want to know is what their understanding is of their illness. Then, you want to find out how much they want to know about their illness. I'd say a majority of patients are very involved in their care and want to know as much as they can. But there are some people who don't want to know anything and they would prefer you to discuss it with their spouse or their children. In studies done by palliative care centers, physician prognostication in advanced illness is largely inaccurate. Our overall survival estimates tended to be incorrect by a factor. After discussing a patient's illness and prognosis, now is the time to get their preference for advanced directives. For our healthier patients, it's usually pretty easy. I've been able to have this conversation in about 5 minutes or so. A majority of them would prefer a trial of resuscitation, and if there's no chance for meaningful recovery, then withdrawal of life support. Now, I think the key phrase here is meaningful recovery, as this can mean something different to everyone. I think it's important for patients to understand that once they've undergone CPR, there's not always a guarantee that they will improve back to their current condition. There's a chance that they could have to live in a nursing home, have a feeding tube, be on a ventilator chronically. When I talk about this, I usually get looks of horror from patients. My mentor in palliative care told me that if her kids ever put her in a nursing home, she would haunt them from her grave. A few weeks ago, I had an 85-year-old woman with severe AS come to my office. We did the annual wellness visit and then we were talking about advanced directives. She really hadn't thought about them at all, but she did know that she did not want to have any kind of cardiac surgery. And her most important goal was to have a good quality of life, continue to live independently, and she didn't want to be a burden to her children. I reassured her that if she got sick, she would go to the hospital and we would do everything that we could to make her better, whether it was IV fluids, antibiotics, medications. But if despite all of our interventions she continued to deteriorate and her heart stopped beating or she stopped breathing, we could either be aggressive and do CPR, put her in a breathing machine, or allow her to pass comfortably without any other pain or suffering. Given her severe aortic stenosis, we discussed that CPR probably would cause more pain and suffering and most likely wouldn't work. After reviewing all the information, she felt comfortable being DNR and DNI. I think it's also important for patients to feel like once they become DNR, DNI, that it doesn't mean that we're not going to do anything or that we're giving up on treating them at all. In addition to deciding what their preferences are, the next important step is to share it with their family. By having family members hear it from the horse's mouth, so to speak, it will prevent any conflict down the road. If the family or healthcare proxy understand their patient's wishes, there shouldn't be any arguments about treatment options. And I also tell the patient that by sharing their wishes with their family, it can help alleviate any guilt that they may feel as they carry out their wishes. A lot of families feel like they're killing the patient, when in reality, they're just respecting their wishes and doing what they would like. It can be helpful and comforting to identify support systems that patients can turn to. For example, family, friends, maybe a religious organization. Also, we can offer them the resources through Summit Medical Group, such as behavioral health, care management, social work, and they may also be able to identify support groups in the community for them. At the end of having this conversation, I think it's important to summarize what you've discussed, make recommendations to ensure that the treatment plan reflects what's important to the patient, review this with them, and reassure them that you will do everything you can to help them through this. It's not mandatory that they make the decision on the advanced directive on the first time you bring it up. You may need to introduce the topic at the first visit and then bring it up in subsequent visits before they can make any decision. The next few slides will talk about how you document the conversation in Athena and how you can bill for it. The advanced care planning visit has to be a face-to-face encounter. You can't do this over the phone. However, the patient doesn't necessarily have to be present. You can have this conversation with a family member as well. It can be in your office, in the hospital, in a subacute rehab facility. Medicare understands that sometimes these decisions cannot be made in one visit, so you can bill for these multiple times per year as necessary. And remember, both specialists and primary care physicians can bill for this visit. For example, the primary care physician may begin the conversation in a patient with Alzheimer's disease or renal failure, and then the neurologist or nephrologist can have a second advanced care planning visit to discuss further prognosis and treatment options. An MD, APN, or PA can bill for this service. It can be billed in combination with an E&M code, but you have to keep in mind that this is a time-based visit and you need a minimum of 16 minutes to bill for it. You can use the template in Athena to document for it. When I have these quick discussions with healthy patients, they rarely take 16 minutes and I don't bill for them. This is the documentation that's required when billing for an advanced care planning visit. If you use the template in Athena, it's all pretty much self-explanatory. However, the one thing I want to emphasize is that you have to document the amount of time spent. You need a minimum of 16 minutes to 45 minutes to bill. And as we discussed earlier, a pulse completion may result from the encounter, but it's not required to complete any form during this visit. You can find the template under Reason under the Review tab or under the Physical Exam tab under Procedures. These are screenshots of the actual encounter. And for each box, there's a convenient list of drop-down choices. The template is self-explanatory and very easy to use. There are different options under medical necessity and goals of care that you can select as well. You must document how much time you spent doing the advanced care plan. Anywhere between 16 to 45 minutes is a 99497. If it's greater than 46 minutes, it's a 99497 plus a 99498. However, you'll find that if you spend more than 45 minutes discussing advanced directives with a patient, you really aren't getting anywhere, and it's probably best to stop after about half an hour and bring them back for another visit. This is the New Jersey's Practitioner's Orders for Life-Sustaining Treatment, or the PULSE form. It should be found in all your exam rooms, and if it's not, you can have your staff print it out. You can Google it. Under goals of care, I always write quality of life and comfort care. And if your patient has any other personal preferences, they can always add it in there as well. After completing the rest of the form with them, I sign it and I have them sign it. It's important to let them know that these wishes are not set in stone. For example, if next week they change their mind and they want to reverse everything that they did in this PULSE form, it's as easy as completing a new one. I also make multiple copies for them so that they can share it with their healthcare proxy or their family members. This form is a good way to have them introduce the topic with their family if they haven't discussed it before. And it can also serve as a guideline so that they can let their family know what their wishes are. This form should be very visible. I encourage them to put it on a magnet on their refrigerator. Because, for example, if they choose to be DNR or DNI, and if EMS comes and they don't see a PULSE form, by law they're obligated to do full treatment and all heroic measures, even if it's against the patient's will, as there's no documentation. You can get 1.5 RVUs for the initial code and an additional 1.4 RVUs for each additional 30 minutes. To summarize for the last slide, advanced care planning is important because it improves the quality of care and patient and physician satisfaction. It can lessen conflicts between patients and their family members, and it cut cost. We should make it a part of the annual wellness visit. There's no pressure to complete the PULSE form, and sometimes just introducing the topic is helpful. If the patient makes a decision, you should complete a PULSE, use the template in Athena to document the conversation, and bill for the advanced care planning visit if you've spent at least 16 minutes. If it's a particularly difficult patient, please feel free to refer to one of our geriatricians for assistance. These are our patients. They know us and they trust us, and they look to us to give them information and guidance about their health. If you have any further questions, comments, or advice on this topic, please post it on Yammer. Thanks for listening.